Hello, hi, Dr. Ismavel. Hello, good morning, good afternoon, and good evening to everyone joining us from all over the world. We're very excited to have you all here for the GASOC Innovation in Global Women's Health session. We're very, very excited to welcome over the next 2 hours several clinicians, innovators, and pioneers that are really finding innovative solutions to the most pressing problems in women's health today. So thank you very much for joining. Pop a message in the chat to tell us where you're joining up from today, so we can really see where we all are from, joining all over the world today. I am going to pass over to Dr. Nanyangwe Chikasa, who is our Obsangani rep, the GASOC Obsangani rep, who will be introducing our first speaker. Thank you everyone for joining, and let's keep the discussion going in the chat. If you have any questions for any of the speakers at any point, please pop the questions in the chat and we will ask the speakers the questions. Thank you very much. Nanyangwe, over to you.
Hi, good morning, everyone. Thank you so much, Dr. Vijna. Dr. Ashwini will be taking the first speaker, and I'll come through next. Thank you.
Hi, everyone. My name is Ashwini. I'm one of the other Obs and Gynae reps on GASOC, and I am very, very honored this morning to present our first speaker, Dr. Vijay Ismavel. Dr. Vijay Ismavel and Dr. Anne Miriam are a remarkable married couple who have pursued an inspiring career in global health work in Assam, India. Dr. Ismavel as a pediatric surgeon and Dr. Miriam as an anesthetist are both alumni of Christian Medical College in Vellore, and they have worked against the constraints of societal norms to reopen the Makunda Christian Leprosy and General Hospital. It had previously been closed for 10 years, but today the institution is devoted to providing healthcare for leprosy patients and marginalized communities. Over 30 years, they have refined a visionary approach to the Makunda Model, which focuses on high-quality, low-cost, sustainable approaches to healthcare provision in remote areas and identification of individuals unable to pay for access to these services through a shared meals test and vitals assets test. This model has been studied by Wharton School of Business for its impact and recognized for efficiency in providing accessible healthcare. At present, the hospital has over 200 beds and has nearly 8,000 deliveries and a large number of surgeries every year. The project has been expanded to include a secondary school, nursing school, and branched hospitals, as well as a biodiversity project, which have all produced transformational impact in surrounding communities. Dr. Ismavel and Dr. Miriam were awarded the prestigious Paul Harrison Award for Lifetime Achievement in 2016 by their alma mater, Christian Medicine College in Vellore. And they have also recently been awarded the WFSA Blood Health Innovation Awards in 2026 for their work on developing a novel low-cost intra-op autotranfusion device. So we are very delighted and very honored to welcome Dr. Ismavel, who will be talking on innovations in women's health, experience from Makunda Christian Hospital.
Thank you very much. I'm just sharing my screen. Can you see the screen?
Yes, we can.
Okay.
Thank you.
So I'm a pediatric surgeon. I'm presently working at a new hospital, which is yet to be set up in the state of Arunachal Pradesh, which is bordering China in a part of India which is between Bangladesh and Myanmar. But I'm going to talk to you about the hospital I had worked earlier for about 30 years, which was described in the introduction. We were working there for about 30 years. So that's my wife and me. we moved from Tamil Nadu in the south of India to this place in 1992 as a part of like Christian service. And this is what motivated us to go. So I had this formula that the transformational impact of one person is equal to the population of a place divided by the number of other people like you in that place. And that is how we, through a series of circumstances, reached this particular hospital. And that is the location of the hospital. And it was, as already mentioned in the introduction, it was a closed down hospital. And it was quite remote. The nearest like secondary level hospitals were about 120 to 200 kilometers in various directions. But it was quite thickly populated. And this was the hospital when we went there in 1992. So the staff of the hospital had already sold off most of the assets to pay themselves salaries. So we had no electricity for about 14 years. And a lot of the equipment had also been sold. And this area had one of the worst maternal and infant mortality rates in India at that time. The MMR was more than 500. And there was a lot of geographical problems like periodic floods. So whenever there was floods, the road access was closed for about 3 months. And there were large numbers of trucks blocking the roads. And there were many stories of people who tried to get to hospital and got stuck in one of these traffic jams with problems like ruptured ectopic or ruptured uterus and died in their cars. So they couldn't get back, move forward or backward. And it was not easy to get to the hospital. People went from forest villages by hammock over many hours before they could reach the road. And then they borrowed someone's private car to get to the hospital because there were no taxis or buses at that time. And this is what the hospital is like. It was like when we left. So, as already mentioned, it was a very busy obstetric center. And today, there are more than 8,000 babies born in 1 year. And that is the 10-bed labor room and the NICU. So research and innovations in these hospitals are motivated by necessity and a desire to provide the best possible services to poor and marginalized people. But there are many challenges to clinicians. So I was the only surgeon. My wife managed obstetrics and anesthesia. And it was very difficult to find time to do innovative work or to publish it. And there was problems with funding, collaborations. But it is still possible to get good quality work done. And that is what I'm going to talk to you about. So we need to understand why people do not want to go to hospital. So this is a lady who had a mass in her abdomen. She went to a doctor and they were told that it could be removed, but the amount of money he wanted was equal to selling their home. So they decided to wait. 6 months later, it was bigger. The same doctor said, I could remove it, but maybe it's cancer. So they decided to let her die so that husband would marry somebody else because they can't waste all the money and then get her die of cancer. So the problem was she was not dying and she had become very large mass in her abdomen. So we removed that and it was 35 kilogram ovarian tumor. The biopsy was papillary cyst adenocarcinoma of the ovary. So we normally would not see such problems except in places which are really remote and rural. And that happens all over the world. And this is the story of another girl who came with massive hemoptysis. And when we did a X-ray, that showed a rounded lesion, which was reported on CT in a center about 120 kilometers away as hydatid cyst. So we thought that's something we can manage. We didn't have a Boyle machine, so we used a EMO, Epstein, Macintosh, Oxford machine to give anesthesia with ether and atmospheric air. But when we opened the chest, it was a teratoma of the lung. So since we didn't know whether it was malignant and what was the extent, we just debulked it. And 4 years later, she came back with a recurrence, which is on the X-ray on the right. And this time we put in that is the EMO machine on the left. And we put in a double lumen tube and did a middle lobectomy. So this was published in an article which also discusses health-seeking behavior, barriers and enablers of health-seeking behavior, as well as when we can assume risk and the ethics of referral and the problems that are faced in low resource settings. We also saw many rare problems. So just to illustrate, we had 5 patients with third trimester primary abdominal pregnancy. So all of them had reached advanced pregnancy and had not been diagnosed till that time. One of them had a mortality, and we had 1 live baby. So all of them had total abdominal hysterectomy, and one had removal of part of the bowel and bladder as well. So my wife is an anesthesiologist. So she had 1 patient who came with acidotic breathing, and she was not diabetic or in renal failure. So an intensivist suggested that this could be thiamine deficiency. So the patient was given thiamine and it recovered. So then we did a lot of studies and found that many women were coming with paraplegia, cardiac failure, and babies, exclusively breastfed babies were coming and dying, and they were all due to thiamine deficiency. So I was doing the echocardiograms in this hospital. And this is neurosonogram showing hyperechoic basal ganglia. And we were then involved with this group based in Oxford called the Matri Research Collaboration, and a series of articles were done on obstetric research. One of them was to understand whether the structural and functional cause of cardiac failure in a patient with in a pregnant lady with heart failure syndrome. So since we didn't have cardiologists, we trained obstetricians to acquire the images, and they were reported remotely. So this was also published. It showed that an obstetrician with 3 days of training should be able to acquire good enough images for remote reporting. This was another study on COVID in India. So this is about the Makunda model. So I was just telling you about poor people. So these are the people who came to our hospital. They didn't have money, so there were refugees. They had food. They could eat from the jungle. But if you wanted money from them, they would have to sell their homes. So how do we provide good quality care sustainably without getting external support? People came very late. They brought eggs and chickens and fish and said, "Can you please treat me with this?" And when you ask them for more money, they sold their homes, the land, their livestock. They came to a hospital and they did not eat food in the hospital. They starved because they wanted to keep the money for the medical treatment. They didn't want a patient to be discharged because they wanted a patient to be discharged when he was sick, because they thought if he died, the cost of transferring a dead body is very expensive. So these are certain things we have done. One investigation or few investigations to clinch the diagnosis. One or few appropriate drugs to achieve the medical objective. Charity was given according to the signs and symptoms. So in the introduction, we were told about that vital assets test. So I'm not going to elaborate, but there are ways to say that this person is poor by observing their behavior in hospital. So they were offered charity before they went and sold their homes. Sometimes they said they will keep the money due and pay on our next visit. But we realized these people never came back because they were embarrassed to come to hospital without the money that was due. So once a year, we wrote off all their dues. And we modified the gold standard protocols. So like, for example, in surgery, common bile duct stones, if you put in a T-tube, you need intra-op and post-operative imaging. The patient stays in the hospital for many days. ERCP is very expensive. So we started doing this choledochoduodenostomy, which is a simple operation and doesn't require imaging. And if there are any retained stones, it is not a problem because we have a proximal bypass. And we modified the charges so that patients are happy to pay that amount. So people wanted to do things like ultrasound, but they didn't want to get admitted into ICU because of fear of expense. So we reduced ICU to a very small amount, and that was subsidized by other departments like ultrasound. We were doing about 25,000 ultrasounds a year. So that was internal cross subsidy. And occasionally when people sold their homes, we sent our staff to get the house back. And also when there was an unexpected complication like a bile leak, the hospital wrote off the bill because that was a huge amount for the patient, but something that the hospital can afford because it is only once or twice a year that we have a problem like that. So we also did not have private rooms, so that the hospital was branded as a hospital for the poor. And this was studied by the Wharton School of Business and published as the Makunda Model. And all this was done without getting external financial support. And the hospital was still had extra money to invest on its own development as well as the other departments. And there was no competition because nobody else was working exclusively with the poor. So when patients wanted private rooms, we referred them to the nursing homes outside. And when they had poor patients, they referred to us. So that was mutually exclusive. And then we found out that patients were not coming for deliveries. And we realized that traditional birth attendants conducted the deliveries at home. And not only conducted deliveries, they were cooking the food and cutting the firewood and all that. So we started talking to them, asking whether they could refer the patients when they had obstruction or bleeding or eclampsia. So when they referred, they had to come because their expert had referred the patient. So with this type of engagement, the number of patients increased significantly. So we need to understand social, economic, and cultural reasons for health-seeking behavior. So they need to be treated as if they are our own family. So here we have nurses carrying the baby of a mother so that she could sleep, or feeding a patient whose relatives have not turned up. And all this led to reduce MMR and IMR in the district. And we spoke about our experiences and published. And these are the early years when there was no electricity and oxygen. This was my first patient with the tracheoesophageal fistula. So that's my wife. We didn't have a ventilator, and the baby was ventilated by hand for 4 days. So all of them were treated like that. And this is that baby, the previous baby. They all did very well. So we had a lot of patients who were ruptured ectopic, and this is how they were managed. The blood was filtered through gauze and then injected back into the patient. This is called the soup ladle technique. And then I developed this concept of a device which could do all this through a closed mechanism. And that was taken up by this digital university in Kerala, and the team developed the prototype. And it was patented 2 years ago. And this is the test results. So it's able to collect 1 unit of blood in 85 seconds. And this was published. And this was a publication in Lancet. And then we got an award in Malawi and then again last year for this device. The second innovation is for a point-of-care diagnostic device to predict preeclampsia using detection of an amyloid-like protein. So this is now commercially available as a test kit in India. So phase 1 trials have shown very good specificity and quite good sensitivity. And now the prospective study is going on. So we can rule out and rule in preeclampsia, and this can be done in the village. And we expect it will cost only about 30 rupees, which is very, very cheap. And there's another one is on CTG, and to demystify it using artificial intelligence, and to give colored alerts to the nurses to say that this is okay or there is a problem, and you should alert the obstetrician. And we were involved in training Dutch doctors doing their MD Global Health and Tropical Medicine course from the Netherlands. And last year we were able to visit one of them in Malawi, managing nearly 15,000 deliveries a year. And while on a visit to Uganda, I found that remote hospitals have very great difficulty in finding donors. So we did another study with the Wharton School of Business to develop a transformational impact rating system, which will tell how much bang for the buck you can expect by investing money in a particular hospital. And in the last 4 years, my wife and me have visited 250 hospitals in India and abroad. And that is current status of hospitals in India, which has also been published. And these are some of the problems that are faced in remote places all over the world. There could be problems with electricity, water. So I had a myocardial infarction, and I have an ejection fraction of only 20%. And then we are not expert in finance, administration, but we are forced to manage all these issues. And lack of support. So for many years, we could not take leave and had to manage large workloads. But this is the situation all over the world, and much worse in places like Africa. So we need people to go, and that is what I would like to end this talk with. If there are some of you who feel adventurous, maybe you should consider going to places of great need where you will be a great blessing and a blessing to many people. Thank you.
Thank you so much, Dr. Ismavel. It was such an interesting talk, especially for, I think, those of us who practice in countries like the UK. And it's amazing to get an appreciation for the challenges that you and your colleagues have faced, and how, despite very low both financial and just support, you have revolutionized the care not only in that area, but in many more who have adopted your models and approach. If that's okay, I'm going to move on to the questions from the audience. One of the questions is that the Makunda model appears to focus on redesigning systems and incentives. Do you think health system innovation and is underappreciated compared with technological innovation nowadays?
Yeah, unfortunately, most of the research is aimed at the rich world, where you can monetize the innovation. But access to care is very important. And for that, we must understand social, cultural, and economic reasons why people do not go to hospital or where we are not able to complete the treatment. And that varies from country to country. So some of the things which we have done at the Makunda model may not work in places like South Sudan, where everybody is poor. So there we might need to have prioritized support directed at the most high impact hospitals and among the most poor people. So I think the elements of the model should be redesigned to each scenario.
And as a follow-on from that, like you said, the Makunda model has a unique combination of sort of quality, affordability, and sustainability. Which elements of those, if any, do you think could realistically be replicated elsewhere?
I think all of them can be replicated. But if you take quality, it will, as you go to poorer and poorer countries and people, we have to measure risk and cost against benefit. So, for example, the decision to refer a patient, if there is the patient will not live to reach the next hospital, then almost any risk is accepted. So you would not do that in an advanced country where there are very good helicopters and ambulances. But in a remote place, we would take that risk. So quality is sort of relative and has to be fine-tuned to the setting. And affordability has to be, there is a difference between costing of services and pricing of services. So that is one of the innovations we did. Pricing is what a person can comfortably pay without selling their vital assets. And that is the target amount of money that we must collect from a patient. So we should think of ways the hospital will function to provide service at that cost. And similarly, sustainability, there are many ways to sustain a hospital. So at Makunda, we were forced to sustain by our own income. And I was telling you that we lived without electricity for 14 years, and that was because we could not afford to have the wiring connected to our homes. So, because we were giving so much of charity. So, we can always find a way to become sustainable. Part of it could be accepting less salaries or working more or working with less people or getting support from the government or from donors. So I think if you work it out, all three elements are possible in practically any setting.
I think it speaks a lot about you, your wife, and your other colleagues who were able to do this and continue to do this. And it is not only an incredible legacy, but I think something that many of us aspire to. One of the other questions are, how can we ensure that ethical guidelines and safeguards are consistently upheld when developing and deploying technological innovations in low and middle income countries, particularly given differences in regulation and oversight capacity?
There are 4 principles of ethics in medicine. First is that whatever we do, it should benefit the patient. The second, that it should not create harm, non-maleficence. The third, that the patient's consent should be taken. So we can always say that there is a 50% chance of death, but that is better than 100%. But we need to explain that out, informed consent. And the fourth is justice. So we cannot say that just because a person is poor, we don't give them treatment, or we are going to refer them. So if all four are practiced, then we are practicing ethical medicine. But in a place like the UK, where everything is covered by the government scheme, you really don't have to think about any of these issues. They are all, at least money is not a problem, and transfer of a patient is not a problem. But we need to factor in all of these in remote and rural areas. And that is still ethics. We are practicing the best way we can to manage in that particular setting.
Yes. And this is a question from Edwin, who is from Ghana. As a lead in innovative appropriate technology, do you provide avenues for mentorship and partnership with other LMICs?
So I'm part of the faculty of the International Christian Medical Dental Association's course on management. So, but if there is anyone who would like to has some ideas and would like opinion, I am very happy to provide that. So if you can contact Vijna, she will connect to me.
That's very kind, thank you. And this is a question from myself, actually. I am in the UK. I'm currently one of the trainees here. So I think my question is, for someone who does not come with that background, is there anything we can do to prepare ourselves if we wanted to in the future come to areas like you have practiced and learn and help and innovate?
So just before this meeting, you mentioned that you had gone on a medical elective to 2 places in India. That is a fantastic opportunity. So if you go to a low resource setting and see for yourself over a period of a week or maybe more, then you will understand what exactly these challenges are. And then you prepare yourself for such a place while you continue your training. And that is what we did. We came to this hospital, worked for 3 years, then went back to the Christian Medical College at Vellore, where we prepared for a long-term service in this hospital with the constraints we had already observed. So that is how we were able to manage. We knew there was not going to be a ventilator. We had no cautery machine for many years. We didn't have a boil machine for many years. And we prepared for a setting like that. And that is how we were successful.
Okay. I have lots to prepare for if this is what I want to do. And I'm just going to ask the chat one last time if there's any questions that you have for Dr. Ismavel. Otherwise, I'll hand it back to Vijna. I think that's it, Dr. Ismavel. Thank you so much for your time and the insight. And it's been a very inspiring talk.
I think I can come through now. Thank you so much. That was just amazing. To hear the legacy, Dr. Anand and his wife has left. So I'm Nanyangwa Chikasa, and I'm the International Obs and Gyne representative for GASOC, and I will be presenting our next speaker. Can everyone hear me?
Yes, we can.
Okay, perfect. So our next speaker is Dr. Katy Kurht, and she's an obstetrician, gynecologist, and researcher at King's College London, specializing in global maternal health with a strong focus on improving outcomes in low-resource settings. Her work centers on translating innovative diagnostics and interventions into real-world clinical practice, particularly in sub-Saharan Africa. She has played a key role in large-scale collaborative initiatives, including involvement in global consortium addressing pregnancy-associated acute kidney injury and a landmark in implementation research, such as the Cradle-5 trial, which evaluated the scale-up of the Cradle Vital Signs Alert device across maternity services in Sierra Leone to improve early detection of life-threatening complications. Dr. Kurht is also the lead author of an impactful research assessing point-of-care diagnostics, including studies on placental growth factor, testing to predict adverse maternal and perinatal outcomes. Her work demonstrates low-cost bedside tools and can accurately identify high-risk pregnancies and support timely clinical decision-making in resource-limited settings. Through her research and partnerships with local health systems, Dr. Katy is advancing scalable evidence-based solutions to reduce maternal and neonatal mortality globally. I am delighted to welcome her to talk about novel point-of-care tests to predict acute obstetric complications. Dr. Katy, you are so welcome. We are so excited to have you, and we cannot wait to hear what you have for us today. Please go ahead.
Thank you so much. Can you hear me?
Yes,
Yes,
we can.
you very clear.
I'm just going to share my screen. Okay, can you see my slides?
Yes, we can see your slides. They're not full screen yet.
They're not full screen. Okay.
They're not full screen.
They should be now, are they?
No, still not.
Okay, let me try and reshare. So share and then what can you see now?
Still not full screen, and we can see your whole laptop screen.
Oh,
Yeah.
Click on play from start.
play from start. That's what I'm doing. So I can see my whole screen.
We can see your whole screen too, your full screen.
Full screen now. Okay, perfect. Okay. Thank you so much. Thank you so much.
Back to a full screen. We can see your full screen. I think you did something there, and then we could see your presentation only. But now, okay, it's back again.
You can see full screen?
Yeah, now we can see your, okay, it's switching between the two.
I think there might just be a delay from when I was switching. What happens if I change the slide? Do you see the slide changing?
No.
Oh dear. I'm not sure what the issue is because on my end it's working well.
Okay.
Can you see them changing?
There's a button down. There's a button down there close to the Zoom button. I think you could just click on that.
A button.
Just
this?
close to the Zoom. No, close to the Zoom slider at the bottom of the page. Just down there.
Yeah, so I'm clicking that now.
That's supposed to do it, but I don't know why.
I don't know what the issue is because I have strong internet connection. Let me stop and reshare. Play from start. Okay, on my screen it's full screen.
Yes, okay, it keeps switching between the two now.
Are you seeing a slide that says overview?
No, we're still on your first slide and it's a full screen.
I am not sure what to suggest.
Could we maybe then, is there a way of you enlarging the present? We can see the overview slide now.
I think it's just a delay, so the slides aren't going to change when I talk. Is the issue.
Dr. Vijna, could we go ahead this way? Or, yeah, I think if she enlarges the slide like that, yeah.
Can you see the slide now just in my PowerPoint?
Yes, just in
And
your
then
PowerPoint.
can you see it changing now?
Yes, we can see it changing.
Okay. Is that good enough to be able to see what the slides say?
I think it is. Yeah, I think it is. We can go ahead, Dr. Katy.
Okay, sorry about that. I don't know what the reason for that is. It was working fine when I tested it with Vijna earlier. Anyway, thank you for the wonderful introduction. So I'm going to talk about some work that I undertook as part of my PhD, but with the disclaimer that this is part of a much bigger body of work that is being carried out by Cribs Global, which is a maternal health research group based at King's College London that I'm very lucky to be a part of. So without further ado, sorry about the technical issues. These are the things I'm going to cover. And I'd like to start with a story, actually. So this is Mary, who was a participant in one of our studies that I'm going to tell you about. Shortly after she gave birth, she was found to have life-threatening kidney damage requiring urgent dialysis. Without the point-of-care creatinine test that detected her abnormal kidney function, she would have died, leaving her newborn baby without a mother. Mary is sadly one of thousands. In Sierra Leone, where this work was undertaken, 1 in 74 women die in pregnancy or childbirth. In the UK, that number is 1 in nearly 9,000. And much like the rest of the world, the major causes of these deaths are hemorrhage, hypertension, sepsis, and those together account for 2/3 of pregnancy-associated kidney injury. And we understand how to treat these conditions. The drugs and the operating theatres we need to treat them exist, but what is often missing is the moment of recognition, the moment a healthcare worker can call for help and say this woman is in trouble. In the UK, this moment is supported by laboratories and specialist backup. In rural Sierra Leone, those tools simply don't exist. So my research question was, can we close that gap to some extent, or could we close that gap to some extent with cheap, novel point-of-care tests that anyone can use, even an untrained healthcare worker, even without labs, even without electricity? And I evaluated 3 such tools, and I'll tell you about each of them briefly in turn. So first of all, to track back a few years to the development of the Cradle Vital Signs Alert device. So this was developed as a low-cost, cheap, highly accurate blood pressure and heart rate device with an inbuilt traffic light early warning system that is triggered by abnormally high blood pressure or by high shock index, which is the ratio of heart rate and systolic blood pressure. It's validated in preeclampsia and eclampsia, and also shock secondary to bleeding and infection. And the Cradle 3 randomized controlled trial evaluated this device as part of a large randomized controlled trial in 10 low and middle income settings, and was found to be associated in Sierra Leone with a significant reduction in maternal mortality and morbidity. And national scale-up of this device, with over 2,000 devices distributed across nearly 700 health facilities and 2,000 frontline healthcare workers trained, has recently been completed just at the end of last year in Sierra Leone. Now, specifically with Cradle 3, what we noted was that there was a more than 80% reduction in hysterectomy, which was the outcome selected to demonstrate very heavy bleeding and postpartum hemorrhage. But hemorrhage referrals actually halved, and there was no increase in bleeding-related deaths. So we thought, is the Cradle doing something that allows healthcare workers to triage women who are bleeding and refer them more effectively? So they're not referring more often, they're just referring the right women. And the Cradle device was also included in the emotive care bundle, which I'm sure a lot of you are aware of. And this emotive care bundle is a bundle of interventions designed to prevent postpartum hemorrhage, including the Cradle VSA, and that intervention was evaluated in over 200,000 women across sites in Kenya, Tanzania, and was found to reduce maternal mortality and morbidity by 60%. So we wanted to look at the mechanism of how this shock index is working. And so one of my studies was the CIPHER study, where we looked at measuring the shock index in women with either bleeding or suspected maternal infection. And we found that in over 1,300 women included in the study with either bleeding or infection, shock index outperformed other vital signs that we use as standard in predicting the women that were going to have a really bad outcome. And you can see the outcomes we looked at the bottom of the bars in the chart there. And you can see from this graph that the risk of these outcomes that we looked at rose steeply with increasing shock index. For example, a woman with a shock index greater than or equal to 1.7, which is demonstrated by the red bars, had a 10-fold increased risk of maternal death compared with those in the mid-range category, demonstrated by the yellow bars. And shock index has most recently been included now in the updated WHO integrated postpartum hemorrhage care guideline as a tool to be able to help triage women with bleeding as to who is likely to have the worst outcomes. So the second study I looked at was evaluating a point of care placental growth factor test for early detection of preterm preeclampsia. And just to give you a little bit of background about placental growth factor, so this placental growth factor is a substance produced by the placenta, which has been shown to be reduced in women with preeclampsia. In the UK, a randomized controlled trial of PlGF in women with suspected preeclampsia demonstrated a halved time to preeclampsia diagnosis and reduced severe maternal outcomes compared to usual care without PlGF, and it saved money treating the women with placental growth factor as part of their risk stratification. And PlGF is now in the UK part of NHS recommended care for women with suspected preeclampsia. However, the problem was that this test, this preeclampsia device, was very large and cumbersome and required a venous blood draw and centrifugation. So it was clearly impractical for low resource setting use, where it was set to have possibly the greatest impact. So more recently, 2 point of care devices have become available, which require finger prick samples of blood and take less than 30 minutes to give a result and don't require any sort of sophisticated centrifugation. So we wanted to look at these point of care tests for the prediction of adverse outcomes, maternal and perinatal, in women with suspected preeclampsia. And this illustration is the graphic abstract that went alongside the publication of the paper, which showed that in nearly 500 women, PlGF near perfectly identified those women who could safely continue with their pregnancy, whilst flagging up other women at high risk who needed urgent delivery to prevent things like death, eclampsia, stillbirth. And so just as an example of this, if you look at the LEPSI device, if the woman had a very abnormal PlGF result, she had a 1 in 5 risk of dying and a 1 in 2 risk of stillbirth. So like massively high risks compared to if she had a normal PlGF result, she had a 0% risk in this study of dying and having a stillbirth. So this is actually a study that was conducted by one of my colleagues, Dr. Alice Beardmore-Gray, just as a sort of way to show you, well, how can we use this PlGF in practice? Well, if you know that a woman is at very high risk of delivery, you're then faced with a challenge, because in a low resource setting that may not have access to good neonatal care, you're then potentially faced with delivering an early baby without the kind of resources to look after that child. So this trial looked at randomizing women with suspected preeclampsia to delivery from 34 weeks, and showed that actually by doing that in the women who need delivery, you reduce the risk of stillbirth by 75%, and you reduce severe maternal hypertension without any increased risk of adverse outcomes in the babies in terms of birth weight and neonatal unit admissions. So the third study that I conducted was the apricot study, where we looked at this point of care creatinine test that I showed you at the beginning of the presentation that Mary benefited from. And this was to look at, firstly, how big is the problem of pregnancy-related acute kidney injury? Because in the tertiary maternity hospital in Freetown, where these studies were conducted, there was no routine testing of renal function, liver function in the women who were giving birth in that hospital. So we wanted to first and foremost find out what is the scale of the problem, and to what extent is it associated in this setting with adverse maternal and perinatal outcomes. And we found a strikingly high rate of pregnancy-related acute kidney injury. In fact, 25% of the women we tested, and there were 1,600 women in the study, had a pregnancy-related associated kidney injury, or we couldn't rule out a chronic underlying kidney problem that just hadn't been picked up from before. And we also found that pregnancy-related kidney injury was associated with very significantly higher maternal and perinatal adverse outcomes that you can see from those striking percentages. And at discharge, worryingly, nearly half of the women still had unresolved kidney injury. And as I'm sure many of you are aware, pregnancy-related associated kidney injury is then associated with a greater risk of chronic kidney disease, chronic hypertension, cardiovascular disease, and future pregnancy complications. So these women are all being discharged from hospital with those risks unchecked in future. And we also found that, unsurprisingly, the independent risk factors for PrACI were age, blood pressure, and preeclampsia. So really highlighting the importance of trying to prevent these conditions to reduce the risk of knock-on effects to the kidney and the other organs. We also found that the optimal point of care creatinine threshold for identifying pregnancy-related kidney injury was 77, lower than the normal adult range, which is consistent with what is highlighted in the more recent literature. So tools alone don't save lives, we know that. And so we gathered together 40 stakeholders, so government leaders, healthcare workers, religious leaders, traditional birth attendants, community members, at a policy lab to design how these point of care tests might work in real life. And their clearest message was that, yes, you can have all these fancy point of care tests, but actually women don't reach the care they need in time as well because their families and communities don't recognize the warning signs. And we focused in this particular policy lab on preeclampsia. And the overall conclusion was that you need to raise awareness of this condition and amongst women themselves, but also their families and communities. So we built an awareness campaign which comprised a docufilm about preeclampsia, national TV and radio broadcasts, and pop-up cinema screenings where we showed the film in rural villages and medical and midwifery school campuses. And in fact, this was a couple of years ago, but just now, in the last couple of weeks, in time for World Preeclampsia Day on the 22nd of May, our team in Sierra Leone led a huge campaign to raise awareness of preeclampsia with a lot of community blood pressure screenings and health facility awareness raising. So I wanted to, if the technology works, I wanted to show you a brief video of those activities, just as an illustration of the importance of kind of engaging the wider community in the research work. So let me just see if this will work. Can you see my screen now? The YouTube?
Yes. Yes.
Perfect. Okay.
Sierra Leone joins the rest of the world to observe World Preeclampsia Day, which happens every year on the 22nd of May. Preeclampsia is a dangerous condition that develops during pregnancy, causing high blood pressure that can harm both the mother and her unborn baby. It can appear suddenly, progress rapidly, and without prompt care, it can be fatal. Yet when detected early, it is manageable and lives can be saved. This year, our theme is Know Her Symptoms. A severe headache that will not go away, blurred vision or seeing flashes of light, swelling of the face, hands or feet, pain in the upper abdomen, and a sudden, unusual increase in weight. These are her symptoms, and every pregnant woman, every family member, and every healthcare worker must know them. Here, at many facilities in Freetown, midwives, nurses, doctors, and mothers are standing together because knowing the symptoms is the first step to saving a life. Through the work of Well-Body Partnership and the Cradle Project, we are equipping frontline healthcare workers with the knowledge and tools they need to detect danger early and act fast. Tools like the Cradle Blood Pressure Monitor and Urine Dipstick have made early detection and referral of preeclampsia more possible for peripheral facilities.
Okay, can you see my slides again now?
Yes.
Yes.
Okay, perfect. So that was just to give a little flavor of some of the activities and the importance of, I guess, going beyond the research and actually thinking about the real life considerations in the context in order to try to bridge the gap between research and actually making an impact and a difference in a sustainable way. So I suppose just coming towards the end of the work, the body of work is a kind of roadmap, not just for the tools to put in a health worker's pocket, but for how to get the right woman to the right place at the right time. And these tests are relevant in a low-income setting, but also a high-income setting, where unfortunately, as we can see from Embrace reports, inequity persists. And at the moment, I'm working with the South East London Trust, where I work clinically, to introduce this new point of care PlGF test in our services for the women we see. And the barriers are obviously different for pregnant women in the UK to Sierra Leone, as illustrated at the beginning of my talk. But the importance of seeing things from where the women are standing remains the same, whatever setting you're working in. And can we use these tests to change the narrative for women and mothers like Mary everywhere? So what's next? I guess we have ongoing FCDO and NIHR funded programs of work, which is looking at the other parts of the pregnancy journey. So early pregnancy screening to determine early in pregnancy who's at risk of preeclampsia, who's at risk of anemia and postpartum hemorrhage. And also looking at what some people refer to as the fourth trimester, so the postpartum period. So these women who have suffered from complications of pregnancy, like preeclampsia, like pregnancy-related acute kidney injury, their journey isn't over when they have the baby. They are at risk of long-term health complications and cardiovascular disease, which is now the leading cause of death in women. So one of our programs of work is now focused on that postnatal period, and can we find a way to follow up women in a contextually appropriate way that allows us to improve and moderate their long-term risks as well as the risks during their pregnancy. So I think I'm a little bit ahead of time, but I'm very happy to take questions. If you want to find out more about the work of Cribs Global, please feel free to either email me or visit the website that I've put on the screen here. And if you want to watch our little docufilm we made about preeclampsia, I've put a QR code here. And yeah, that's it from me, but please feel free to ask any questions. And thank you for listening.
Thank you so much, Dr. Katy. That was an amazing presentation. I think I speak for all of us when I can say it was really enlightening with all that you're doing. We've come from the Makunda project, and now we're here with Katy doing a lot in Sierra Leone and other African countries, looking at maternal care, which is something I am also very passionate about. So thank you for that. We do have a few questions. The first question from kindly note that you can post your question in the chat and we'll be able to read the question for our speaker, just to have a little less traffic. So Dr. Anand asks, what is the cost per test for the PlGF device?
So that's a really good question. And at the moment, because the device in low resource settings is used only in a research context, they haven't yet created a sort of low income price bracket, but we're working very closely with the manufacturers of the Lepsi device in particular, and they are very keen to make this accessible and sustainable in a low resource setting. So one of the things we're working on them with is like procurement pathways, and also making the test sustainable in terms of cost on a bigger scale. So hopefully I'll be able to update you on that in the coming months.
Okay, thank you so much. I think Alexander Chikonga also asked, what is the cost of PlGF and the reagents? I think that does cover that question as well, unless you'd like to comment a bit more on that.
Yeah, no, I think the same really. And just to say, so obviously the study I did was a prospective observational study where the women and the clinicians were blinded to the PlGF result because we wanted to make sure that it performed in the way that we would expect compared to the gold standard UK test, which it did. So the next step, which is ongoing now, is a trial where the PlGF is actually incorporated into the management pathway of women. And we're also, as part of that study, going to be looking at the cost benefits of using the test in the care of women. So the study, that particular study is taking place in Sierra Leone, Zambia, Brazil, and India. So after that trial is finished, and following further work, as I mentioned, with the manufacturer of Lepsi, we should be able to have updated costings that obviously have a huge impact on the use of the test going forward.
That's exciting. And I'm in Zambia, so that's exciting. Thank you so much, Katy. We have Elizabeth Chiti, who says she loves being part of the maternal studies in Sierra Leone here at AWC. You might have worked with her as well. So thank you for that, Elizabeth. And we have another question that says, what have been the biggest barriers to translating point-of-care maternal diagnostics into routine practice in Sierra Leone versus the UK?
So that's such a good question. As I said, so to date, like the studies that I did, they weren't part of routine practice. They were being purely evaluated just for feasibility, kind of logistical feasibility and accuracy. But I would say just from the things we learned during that study and the things we knew that we would need to think about in the design of future studies and also integration into care is, although the device is portable, it requires charging probably on a daily basis. And in a more rural setting in Sierra Leone, obviously electricity is an issue. And so you have to think about, well, where do I locate these machines that mean that I can connect to power to charge them after a day of work, so that we don't face, running out of electricity and not being able to use the device. The other thing, I suppose, is the kind of, although the tests are quite heat stable, they have to be kept in the long term. The cassettes need to be stored in the fridge. So, you can take them out for quite some time. So we were able to take them out and then go and do all the tests we needed to do. But ultimately, again, you wouldn't be able to store them, for long, long periods of time in a hot, 40-degree heat setup, so you would need some way of refrigerating. So that's obviously another consideration. So it's more those kind of logistical supply chain training issues. And I think important also to remember that point of care is it's a great idea, but it's not a fix-all solution. There are lots of logistical problems to consider in the context of using point of care in a low-income setting. And obviously in the UK, you don't have those issues with being able to plug the device in and keep the test cassettes cold and all of those things. So it's much more straightforward from that perspective.
Thank you so much, Katy. That's real life barriers and challenges right there. We have another question. We know that maternal mortality in the low to middle income countries is largely preventable. How should health systems decide between investing in new diagnostic technologies versus strengthening basic infrastructure and workforce capacity? I think they would like your opinion on that.
Again, I think that's such a good question, and it's such a tension and something that I thought about a lot whilst carrying out the work and also writing ultimately the thesis where it sort of all was brought together. And I think there's a strong argument for putting a lot of emphasis on focus on doing the simple things properly before you start introducing lots of sophisticated tech on top of a system that perhaps some of the basics need more work and more investment and more thought. So I think it's kind of focusing on the low-hanging fruit and making sure those things are working. But if you can add in, I suppose the thing about the point of care diagnostics is that they're designed to be very simple. They're designed to be accessible so that you could potentially task shift, so that someone who is a community healthcare worker could do these tests, and task shift from the kind of resource stretched healthcare facility where you can then reserve those healthcare workers for helping the women with more sophisticated problems. So I suppose I do think that we shouldn't be introducing lots of very fancy tech that is not at all sustainable. But I hope that these point of care tests are actually enabling a kind of simplification of some of the systems that are not quite working properly, rather than making things more complicated.
Right. Thank you. And I have a question, Dr. Katy. So you have worked a lot with the placental growth factor testing. In your view, what is the single most promising biomarker or panel of markers for predicting acute obstetric complications like preeclampsia or PPH? And what evidence do you feel is still missing?
That's a really difficult question to answer. Obviously I'm very biased, and there are many, many, many biomarkers that are relevant to pregnancy. But I think in terms of what we already know about preeclampsia, placental growth factor is a very good adjunct because it allows us to change care in a very tangible way. So, for example, the reference I made earlier to the fact that if you know a woman is at high risk, we now know with the evidence we have from the Cradle 4 trial that it's safe to deliver the baby, right, from 34 weeks. And so you can really change management for that woman, versus if a woman is well and has a low normal PLGF result, she can safely remain pregnant. And right. You avoid multiple interventions that are costly and difficult for the woman. So I think PLGF has the greatest ability at the moment to sort of change the care pathway for the woman and change the amount of intervention that needs to be offered and that's obviously beneficial to the health system. But like I said, the trial that's evaluating that now will really show us and quantify the kind of numbers and the impact on care that has. So watch this space and see what that trial says. But that would be my sort of impression, following on from the work that I've done.
Right. Thank you, Dr. Katy. That's we'll be watching that space definitely. And we have one more question from Dr. Anand, and he asks, how early in pregnancy does the PLGF test reliably predict preeclampsia?
It can be used as part of first trimester screening, but you use a different threshold. So one of the studies that's running in Sierra Leone, or just about to start running actually, the Cradle Smart study, is looking at using PLGF earlier on in the pregnancy in the first trimester as part of a bundle of other tests that predict a woman's risk of developing preterm preeclampsia. And the reason that's really beneficial is because you can then offer aspirin to the women at high risk, which then very significantly reduces their risk of developing preterm preeclampsia later on. So you can use it in the first trimester. It's a slightly different type of the threshold of PLGF than the one you use when you are testing women who present later on in the pregnancy.
Right. Thank you so much, Dr. Kurht. Are there any other questions? Please feel free to type them in the chat. I see no new questions at the moment. Right. Thank you so much, Dr. Katy. That was so good. And we'll be watching this space. I think a lot of us are interested and are passionate about maternal health. So we're excited to look to it. Thank you so much. I'm going to hand over to Ashwini, who will present our next speaker. Thank you. Oh, there's one more question, Dr. Katy, from Rasmus Okonkwo. Thank you. The question is, can it be used after 37 weeks?
So the evidence at the moment is for it to be used up until 37 weeks. But from 37 weeks in women with preeclampsia, we know, the WHO guidelines is quite clear that we should deliver the women anyway. Mm-hmm. So the PLGF is then of limited value in a kind of decision-making tool because we sort of know what to do anyway, if that makes sense.
Yeah, it does. Thank you so much. Thank you, Dr. Katy, once more. Very enlightening presentation. We appreciate that. Dr. Ashwini, over to you.
Thank you, Nana. I am now delighted to present Dr. Fran Conti Ramsden, who is a UK-based obstetric and gynecology registrar and a Chadbourne clinical lecturer at King's College London. She is passionate about transforming women's health through technology and innovation, combining a NHS clinical experience with a MRC-funded PhD, recent NHS Clinical AI Fellowship, and a commercial role as Chief Medical Officer at Meggie Health. She works at the intersection of clinical medicine, data science, technology, and AI. Her current program of research focuses on leveraging advances such as smartphone-based vital signs capture and large language models to drive forward scalable innovation in maternal cardiovascular care. She has published over 20 peer-reviewed manuscripts, including award-winning work recognized by the Hypertension Journal. She was awarded an AI Visionary Award in 2025 by Health Innovation KSS and was the recipient of the 2024 International Society for the Study of Hypertension in Pregnancy Zuspin Prize. She will be talking today about AI for community, patient engagement, and language scaling maternal cardiovascular health. Over to you, Fran.
Hi, thank you. Can you hear me okay?
Yes, we can. Yeah.
Wonderful. So thank you very much for that introduction, and my pleasure to be here today. Thank you for the invitation. So yes, I'm going to be talking about some uses of AI, thinking about how we can use community channels for engaging women, and then engagement of women themselves, and thinking about other ways we can use technology for personalization in the field of maternal cardiovascular health. So I think Ashwini has done a wonderful introduction, but I wear three hats primarily. So I'm a clinician. I work 50% at Guy's and St. Thomas's Hospital. I've started my postdoctoral clinical lectureship at King's, and I've been working as Chief Medical Officer at Meggie Health for about 18 months. So I'll start, I think this is probably common knowledge for most people, but why do we care so much about maternal cardiovascular health? So starting with pregnancy, and then I'll move into sort of the bigger picture of maternal cardiovascular health. Hypertensive disorders affect over 1 in 10 pregnant women. Recent studies in the US in particular show that this burden is increasing as much as 17% of hospitalized deliveries. There's a disproportionate burden in low and middle income settings. So this is a nice visual from a review from a couple of years ago, and it's color coded so you can see the kind of the hot spots in terms of incidence. We know that maternal hypertension is one of the major contributors to maternal and infant both mortality and morbidity. And interestingly, what we've seen, particularly in the UK and other high income settings, is that with good antenatal care and proactive care, you can reduce much of the maternal mortality. The infant mortality is still much trickier with things like prophylaxis, recognition of high blood pressure, treatment of blood pressure to below treatment thresholds, and proactive delivery rather than waiting for bad things to happen. However, when we look globally, obviously the picture is very, very different. And even within high income settings, there's still a huge amount of variability in both how the diseases are managed and in terms of outcomes. And there's a real need for scalable, low cost solutions and innovation. And that's something that is something that I think is really important, an area of focus of my work. And what we're increasingly understanding is that what happens in pregnancy gives us a lot of information about a woman's longer term health. And why this matters in particular when we think about pregnancy hypertension is because cardiovascular disease is actually the leading cause of death in women worldwide. So it's more common to die from cardiovascular disease and breast cancer, but I think that's just something that is not common knowledge at all. And I'm thinking about specifically cardiovascular disease, hypertension. So high blood pressure is the #1 risk factor, but the majority of hypertension worldwide is unrecognized. So people don't know they have it because it can be completely asymptomatic and therefore it's untreated. And that's the sort of the #1 modifiable risk factor. And what we now have very clear epidemiological data on is that for those women who develop blood pressure problems, including preeclampsia during pregnancy, they're at a much higher lifetime risk of cardiovascular disease. So 2 to 4 times increased risk. So 4 times increased incidence of chronic hypertension and 2 times increased risk of things like stroke, heart failure, heart attacks, cerebrovascular disease. This is also dementias and things like that. And sadly, what happens at the moment is that women will receive her pregnancy care. She may develop one of these disorders, and then there's very little that can be that's currently done as part of routine clinical practice in any setting. So that's high income as much as low income. There are some centers in the US, they are starting to set up cardio-obstetric clinics, but this is still very, very early and innovative. So the majority of women do not receive structured follow-up. So we have this real missed window of opportunity for interventions. So this is really the focus of what MEGI does. So MEGI is a company that spun out from a Croatian cardiovascular clinic a couple of years ago, and they really set out initially trying to solve the problem that they would do all these sort of high-tech treatments of cardiovascular patients, so treating heart attacks, strokes, heart failure, etc., in hospital. Then these patients would go home, and then they would be getting sick or die, not because the initial disease wasn't treated well, but because simple things like remembering to take their blood pressure, remembering to take their medication, these were the things that patients were finding difficult when they went home. So the company started out as a digital health solution to really help manage patients in between their episodic hospital appointments. And so they had up between about 5,000-10,000 patients on the initial platform. That was both men and women. And then they started to see real differences in blood pressure patterns and cardiovascular risk factors between men and women. And that's when they really started to focus on women's cardiovascular health specifically. And I joined about 18 months ago. And that's when we really started to think about pregnancy as a window into lifelong cardiovascular care. And our vision really is thinking about cardiovascular care for women across the life course. So thinking about how can we predict risk, again, thinking about what's scalable, what's really easy to deploy, making it as simple as possible for both women and for clinicians. But then also thinking about risk modification. So both sort of targeting aspirin, prophylaxis, who should be getting it, as adherence to medication, aspirin and blood pressure medication, thinking about adherence to medication and improving blood pressure control around delivery and in the early postpartum, when we know there's really good data now to demonstrate that this is very likely to lead to lasting cardiovascular benefits in later life, and focusing on that primary prevention. And we're doing lots of work, data science, looking at sort of multimodal prediction models. So really thinking about how we can improve cardiovascular health across the life course. But of course, it's all very well developing all these models and fancy algorithms. But one of the first challenges that we're dealing with right now is how do we reach women when most globally do not have access to doctors skilled in maternal cardiovascular health? So actually the first challenge is actually reaching individuals. And now this is true in low and middle income settings, and I think Katy will have spoken very eloquently about that. But this is also true in many high income settings. So we're also active in the USA. And in the USA, many women are uninsured, and many of them live in what called maternity care deserts. So that means that they are 5 or 6 hours away from a hospital, and they have very, very difficult access to skilled medical provision. They don't have very many midwives in the US, for example, so it's very OBGYN led, and that's very expensive. So there's real access barriers actually in numerous settings. So what I want to talk about now is some of the ways in which we're trying to use AI and technology as a tool to try and enable care and scalable care, and thinking about this both from the kind of education perspective, engagement, and how we can personalize things for individuals. So there's 3 things that I want to talk about today. So one is around community, the second is around engagement and trying to lower the barriers to getting care, and the third is around personalization. So the first is community. So one way in which we've tried to reach women sort of outside of formal healthcare routes is through community programs of education. So we've developed a high-risk pregnancy course. It's a 6-week course, it's a sort of hybrid learning model whereby individuals, primarily at the moment doulas, but also community health workers, cultural health navigators. So individuals who are active in communities, who work with women during pregnancy, birth and postpartum, but don't necessarily receive very much dedicated training. And this is, we've now trained over 800 community and doula birth workers across the US, the UK, Kenya, Brazil, and Europe. And one of the ways in which we're using AI here is both for the education piece and for the community piece. So as well as having the pre-recorded videos and the weekly sort of live webinars, all of the individuals who are taking the course have a 24/7 available AI tutor. So they're able to talk about any content related to the course, say, I want to understand better what are the risk factors for preeclampsia, or tell me more about aspirin. When should women be taking it? Is it safe? And so they can interact with the course content at any time and really get a personalized learning experience. They also, through the app, have a community, so they can interact with each other. So the other delegates on the course, people from previous cohorts, to again to share their understanding, their challenges in their local area. And this has proven really successful. So we're primarily focused on hypersensitive disorders. The certification, the course covers high-risk pregnancy more generally, but really focused on maternal cardiovascular health. But here you can see some of the improvements that we've seen in some of our early cohorts, and analysis is ongoing with the later. So seeing big increases in postpartum preeclampsia awareness, understanding what symptoms can be indicative of preeclampsia, and also understanding what is a normal and an abnormal blood pressure in pregnancy. So we're really then using these community workers who are already active in the communities where women are sort of living and breathing and existing as the channel then to start to engage patients. So those individuals who've been trained then invite their clients or the individuals that they're working with onto using the Megi platform. And the idea of the Megi platform is to make it as straightforward as possible. So always thinking about making things easy as possible to engage women and to help support them with their cardiovascular health in pregnancy. So we try and be what's called omnichannel, so giving different options of how we deliver the technology depending on what works best, depending on the scenario. So we have we can deliver the platform through WhatsApp Messenger. So that's WhatsApp in lots of countries is used really, really highly. So that can be a really effective way of engaging individuals. We also have a dedicated app. And in both forms of the technology, essentially what the main functions of the platform are to support women to understand, what is blood pressure, what is, why do we need to monitor it, how to monitor their blood pressure, how to take blood pressure readings accurately using cuffs. It allows them to record their readings, to visualize them, and also provides that conversational support either through WhatsApp, or there's the kind of the more kind of bot looking thing through the app as well. Sorry, it's just my son, if you can hear him chattering away in the background. We also have the option for voice recognition. So if written literacy is an issue, there's also the option to interact with Meggie via voice as well. And that's a capability that we're expanding. And really, I think what's important here is that people, especially younger generations now, they are getting used to chatbots. They are used to getting their information support from LLMs. Even things that you can Google, people are increasingly turning to AI for their information. And so, I think we do, if you're trying to make things straightforward and easy, you are competing with that ease of experience of popping something into ChatGPT. And that's really what we're trying to deliver, but within very, very carefully curated knowledge, safety guardrails, benchmarking, and working towards Class 2A software as a medical device. The other component, of course, is actually the hardware challenge. So how do you get blood pressure monitors to everyone that needs them? And that's a really big challenge. So that's how we operate at the moment. So we are offering blood pressure cuffs as part of the packages that we are that we're setting up, but we're also very much looking at how we can use other technologies again to try and remove the friction, to remove the barriers to access and to monitoring. So one area that we're exploring at the moment is using smartphone-based blood pressure monitoring. And this is something which has been validated in the general population. I think there's still, the jury's still out as to how well this works in kind of hypertensive ranges, but certainly it hasn't been well enough validated in pregnancy. So we're starting to do some collaborative work to get to see how well this could work, thinking about two kind of use cases. So firstly, could it be used as a substitute for a cuff? So could this technology be used safely as an alternative? Or alternatively, could it be used for screening? So could you, at least work out who is very likely to be normotensive and who is at risk of being hypertensive using this kind of technology to help you kind of work out who needs to have blood pressure cuffs when you're sort of thinking about a population type of approach, as well as integration with wearable devices. So again, these are all areas in our sort of R&D pipeline where we're really thinking about how can we use the technology that, despite many challenges in rural settings, in low middle income settings, smartphone penetration can be incredibly high. So thinking about how can we best utilize the devices that individuals already have in their pockets. Just a very brief note here to say that use of generative AI in healthcare is it is not a straightforward thing. So I think any of you who know much about how generative AI works or large language models, there's a lot of risk. There's a risk of hallucinations, anchoring biases, all kinds of challenges. So we take that very, very seriously. And a lot of the work that we do is around benchmarking and safety of using these models. And so this is just an example of the clinical dashboard. So we currently monitor all of our conversations to ensure that they are passing our safety standards, and sort of increasingly seeing how we put together sort of LLM as judge with human reviewers to ensure we've got a real safe pipeline, because we all know about how AI can get it wrong. So I'm going to finish thinking about personalization, and what I'm going to do is just talk through one of our current pilots. So this is a pilot that we have ongoing with a health system called Valleywise Health in the USA. They are a health system that, as part of their work, they serve refugee and immigrant communities. And when we sort of were setting up the pilot, their real challenges were that they had pregnant women in these refugee communities that had very little access to antenatal care, and very few of them obviously spoke English, and they wanted to see if they could use our technology to upskill their existing cultural health navigators, who are individuals who work within these refugee communities, to try and help them to get the care that they need, to upskill them in pregnancy care, high risk care, and then to deliver through them to find the women who are pregnant and to offer them the technology and see if they would engage. So what we needed to do was to personalize the platform, the capabilities. So we needed to be able to deliver the platform in 6 languages. And again, this is an area where AI can really, really, really help. So that took us about 3 weeks to get all of our pipelines working in Dari, Pashto, Arabic, Swahili, and French, as well as English. And we got all of that sorted. We then refined our training program to make it suitable for the cultural health navigator role. And they were onboarded onto the platform, completed the training program over a 3-week period, and then they've just started to invite their clients on in the last couple of weeks. And so in the first week of the pilot, all the 6 languages are live. We've trained 5 community cultural health navigators. So far in the first week, they have invited 16 pregnant women who've enrolled. More than 50% of them, so 62% of them, have started submitting BP readings, which is really, really exciting. And these are being monitored by the local clinician who works in the refugee clinic. And there's been more than 50 chatbot conversations. And the things that have really stood out to me is reviewing these conversations, that there are women asking about headaches, there are women asking about potential early labor, potential preterm labor, and they're very often asking in their own language, saying, is this normal? Do I need to do something? Is this right? And so I think it's going to show the potential value of this technology, that individuals who have got real access barriers are able to use this to understand, hey, no, this isn't right, you need to seek medical attention, that would otherwise potentially be sitting around not really sure, not having the confidence to do that. And that's where I see a real value of this, is to potentially empower individuals to both understand what is potentially concerning, but also say, okay, so let's do something. Contact your cultural health navigator. They can help you understand what the next steps are. So just a couple of clinical perspectives, I think, from my journey in the last sort of 12 months, is that AI is moving at an incredibly fast pace. And I think something that I didn't really understand until I was working in the tech sector is the pace of change is days and weeks. So these models are improving almost on a daily basis. So if you're someone who hasn't yet played with AI, you should start playing with it just for personal stuff. Don't put anything confidential or anything important on there, but just see what it can do. Like, ask it to help you prepare a presentation or to help you do something like an admin job, and then try it again 6 weeks later and see the difference, because the speed of change is phenomenal. So there are unprecedented opportunities to engage, educate, and provide care for people at scale, and this is already happening. So we know that AI is being used globally. Almost 1 in 4 chatbot conversations are around health. Almost 1 in 4. There's like millions and millions of healthcare queries every day. And my worry is that those are happening on platforms that are not, they're not regulated, they aren't benchmarked. So there's a lot of work to do to get the technology safe. But whether we like it or not, that's how the technology is being used. And I think also when we start thinking about technology, people often think about sort of technologies like it can solve absolutely everything. It's like, oh, we'll just throw tech at the problem, it'll be great. I think it's much more about thinking about how do you get human and technology to work together? Like, where do you need humans? Where do you need technology? And that's really the approach that we have at Meggie, thinking about actually, you know, you can't just throw technology at people and expect it to work. Whereas actually, if you're educating and informing individuals who are embedded in communities, who are already in a position of trust, helping them to get the skills and knowledge that they need to be able to support pregnant postpartum women effectively, and then using them as the channel by which you're offering these tools, we think that's a much more likely to be successful approach. And again, really thinking about how we can use technology to augment and work together with key human individuals. But thinking about the whole pathway, you know, technology is going to give us the ability to completely redo everything, but really think about, you know, where do you want and need humans in those pathways? And then finally is around trust and safety. So if you're working with AI, but particularly generative AI, trust, assurance, and safety are absolutely essential. Women, generally speaking, have got lower trust in AI. And without trust, you know, people won't use it and it's not going to work. So I think spending the time to ensure the safety and to really build up that trust is absolutely critical. So thank you very much. I hope that's been interesting and giving you some food for thought. I think it's a little bit of a different perspective from some of the other speakers. I'm on LinkedIn if you want to follow my work. We also are often looking for help and we have internships for clinicians who are sort of interested in finding out a little bit more about digital health and AI. So I will stop there and see if there are any questions. Great. Wazu.
Sorry. Hi, Fran. I'm not sure where. Thank you so much for that wonderful presentation. It was amazing. We've moved from Makunda to maternal health in Sierra Leone and some novel diagnostic pieces to Meggie. And Dr. Fran, thank you so much. That was amazing and enlightening as well. More so that we're moving to a digital space. So there are a few questions for you. The first is from Suraya Awal. She's very impressed. He's very impressed. And they say, how do we key into the Meggie course for our communities? I presume, how do they tap into that course and enable communities also to get some
Absolutely.
of that?
So if you're interested, just drop me a line at fran@meggie.ai. If you also, I'll pop the website into the chat so you can, you know, there's more information there and people can, we run cohorts every sort of 2 months or so. So you can also, you know, enroll directly. But if you have a sort of a program, for example, you know, you have a particular group of individuals in mind, that if you work with community workers or cultural health navigators or, you know, community individuals that you think would benefit from this kind of work, then, you know, we can also talk about tailoring it. And you know, we very much, we're not, our business model centers on health providers and insurers. So we never charge individuals to use the platform. And we also try to keep the education either free or low cost, depending on the situation that you're working in. So we, you know, we're very happy to discuss your particular context and work something out. But if you are primarily serving underserved populations or in a lower middle income setting, you know, I can tell you already that we would provide it free of charge.
Thanks, Fran. Apologies, I had a slight unmuting issue earlier. One of the other questions is, how can we ensure that AI-driven health technologies are sensitive to local culture practices, health beliefs, and traditional understandings of illness, particularly when they are deployed across diverse communities?
Yeah, I think that's a really great question. I think this is something which it comes, I see this in a sort of in a layered way. So I'd say one of the strengths of this sort of community-centered approach is that you have those individuals active in the community who do understand that local context, and also those kind of challenges of, okay, so if a woman is 32 weeks and she's got, you know, crashing new headaches, obviously she needs to get her blood pressure checked, but then actually physically, how does she get to a place that could do something about it? You know, I think that's where having those individuals in the community makes a really, really big difference. Then thinking about the technology itself, I think this is something where, you know, AI actually has got the potential to really learn that level of personalization. So I don't know if you know, but some AI platforms now, you can choose like an avatar or like a persona of like what you want your AI to be like for you. So like, do you want, and I mean, they're hideously over sexualized and commercial. But I think the concept is interesting, that, you know, your AI will learn about you. And there's, again, lots of things to think about in terms of trust, safety, data privacy, but this kind of profiling. And we're starting to do this in a sort of a simple way. So, for example, with the ValueWise pilot, the community worker decides the language. And that's a level of personalization. And that obviously that's very, very basic. But we could also consider other levels of personalization, like literacy level. Like, actually, this woman I know has got really poor written literacy, so I'm going to offer her Meggie by voice, so that like we can overcome that barrier. So there's lots of ways in which technology can be used to personalize and communicate. And I think all of that kind of that knowledge around how does someone want to be spoken to, what their pre-existing beliefs are, these are all things that, like, it's very much like a double-edged sword, because it does feel quite scary as well, but AI can learn that, and it can also learn from the kind of the broader community. And every conversation that you have, and bear this in mind whenever you're having a conversation with AI, it's learning from that conversation. So actually this kind of hyper personalization is completely possible. It's just about giving AI the right data. And I think that that's something that as we get more data and we get more feedback and we understand what works in terms of engagement, we're going to be able to do that better and better and better. Because I think, you know, there is no one size fits all, and that doesn't make it, you know, it wouldn't make sense that one size fits all. And we saw this actually in focus groups, and I'm rambling slightly, but we did focus groups on AI technology, and the difference in opinion was huge. So some women said, I really don't like it being empathetic, because then it's scaring me because it's a robot. And if it's empathetic, that's really discombobulating for me. I just want it to give me very clean facts. I don't want it to be nice to me. You know, it should just be there for information. Whereas there are other individuals saying, I love that that it can be empathetic. Like, I really felt heard. I really felt listened to. So you can see, you know, two women who'd experienced preeclampsia, but vastly different wants and needs and asks of the technology. And AI allows that, you know, and even if not to the degree we want it to today, that capability is going to be coming very, very soon. So I see all of that as things that are definitely going to become possible. But it's really up to the people building the technology to do that responsibly and carefully, and in a culturally appropriate manner. And I think that's sort of, you know, in the setup phase, when we're really trying to work out what people need, that's what's really important to understand, and to ensure that, you know, things that don't fit with, as you say, kind of Western medicine, how we have done things for many years, that we're not putting that in opposition to an individual health beliefs, so we can still respect those, but also ensure that we're keeping them safe. You know, that's obviously the top priority.
Lovely, thank you. I think, like you've said, we can see that AI is changing and adapting and learning, I guess, very quickly. And hopefully that's something that will be easier in the future. Another question about the technology, but this time more about the blood pressure measurements, is how reliable is the use of the smartwatches to measure blood pressure?
Yeah, great question. So I would say I don't know the answer yet. We're working on it. In the main, the pressure-based ones, the ones that use like a pressure sensor, just as a scientist, I'm not that convinced, because I feel like if you're typing or you're moving, that's clearly going to affect the pressure. We are validating, we're doing a study that will be launching in September, where we'll be randomizing women, postnatal women, this is in the UK, to standard of care, which is basically nothing, to the Megi platform plus a cuff, a traditional cuff, or Megi platform cuff and a smartphone, smartwatch made by Huawei. And that's actually got a little cuff in the wrist strap. So it does the same sort of oscillometric BP measurement as a cuff-based device, a brachial arm-based device would do. So that will be interesting, I think, to understand, how well that works compared to the brachial, the traditional arm-based readings. But I think the jury is very much out. There's a position paper published, I think, was it this year or last year, the American Heart Association. And the kind of consensus from the people who've been doing hypertension for years and years and years is that sort of cuffless and wearable based blood pressures is still, people still don't really know how to validate them and what to make of the data, because we're looking at something fundamentally different. If you're truly capturing BP on the go, that is different from what we typically interpret medically for blood pressure. So you have to remember that blood pressure is typically 5 minutes seated, no, uncrossed legs, bladder empty. It's quite a lot of things to think about. No talking, have had rest for 5 minutes, and then you take your blood pressure, and that's what we treat. However, we know that ambulatory monitoring, so 24-hour where you wear it and it goes off every 30 minutes, that gives us so much more information about an individual's cardiovascular risk, to the degree now that we use home BP. Ambulatory BP is really the gold standard, both for diagnosis and for treatment decisions in sort of general adult medicine now. So my hypothesis is that once we understand how to interpret wearable BP data, it may never become a substitute for kind of, a traditional cuff-based measurement, but we may still get a huge amount of information about an individual's cardiovascular risk, but we're not there yet. We don't yet understand quite what it means. And like I said, can we sub it out as a direct substitute for a sort of a rigorous measurement? Or is it something that can be used more for screening? And that's what we're really seeing so far in that world. If you think about things like the Apple Watch and others, they're being used to say you're at risk of hypertension. No one's claiming that they can diagnose hypertension from a wearable watch at the moment. But we'll see with the Huawei inflatable wrist one, whether that actually is sort of moves the needle slightly.
Lovely. And just a quick last question that I'll try to sneak in. This is from Betty Sam, who says, thank you for all the innovations in maternal and newborn health in our settings. My question is, how can policymakers have a buy-in for sustainability in routine care?
Yeah, it's interesting. So, I mean, one of the reasons why I'm doing commercial work is because of that sustainability piece, because someone has got to pay somewhere. And, research is great. And I love, I've been working as an academic for 7 years, but I worry about that sustainability piece of like, who pays for this when the study's over? Who implements this and scales this? And, that's why, I actually, and maybe this is, me turning to the dark side, but I feel like if we want things to truly change how we deliver care and be scalable, they've got to make sense financially, commercially, and because that's how you're going to get that scale. If you think about the fact that almost irrespective of where you are in the world, almost everyone has a phone. And almost everyone has a smartphone. It's because they're so bloody useful, isn't it? And they're so, they can do so much, and they are sort of channeling into everything that we want as humans. whether for better or for worse, they've really got something right. And I think we need to think about innovation in the same way. We need to make it really easy, because I do think it's very difficult. Women's health is incredibly underfunded. If you look at cardiovascular disease, oncology, other areas of medicine have got multiples of the funding that we have, and that's across kind of clinical practice, research, the whole shebang. So I really do feel like we need to focus on, making business cases as well as the kind of the clinical cases, because ultimately, if we can demonstrate, and this is the approach that we take at Meggie, is we will hopefully demonstrate that using our technology improves outcomes and reduces cost, and therefore it will be a no-brainer for insurers to pay for it, because it makes sense on multiple levels. So I actually sort of flip that question around to say sustainability for me is around who is going to be paying for the innovation in the long term, and whether that's through kind of NGO charitable mechanisms, whether that's in sort of fully commercialized systems like the US. But you need to think about not thinking about the cost is a problem, in my view, because I think you need to be thinking about that from the beginning to say, in the long term, who pays for this? How much can they pay for how long? Because that's what's going to eventually lead to it being sustainable and hopefully scalable. And it's getting that path from the beginning, I think is what I hope will lead to like bigger scale change.
Thank you so much. Sorry to have put you under pressure with the time there. It was an extremely insightful talk, I think, about something that we hear about every day, AI, but seeing how this is applicable in healthcare and what we can do as clinicians to help a safe implementation of this, and something that can be wide-reaching. I'll hand over back to Nana so that she can present our last speaker.
Thank you so much, Ashwini. Thank you, Dr. Fran. It has been a wonderful event so far, and I have the privilege of presenting our last speaker. So Dr. Jakub Gajewski is a director of the research program at the RCSI Institute of Global Surgery and an extraordinary senior lecturer at Stellenbosch University. He is a health sociologist with over 20 years of experience in research, teaching, and international project management. His work focuses on implementation science, health system strengthening, human resources for health and global surgery, particularly in sub-Saharan Africa. He has contributed to large population-based studies on young people's well-being, diabetes, epilepsy, conducted in more than 50 countries worldwide. Wow. So he has led COST Africa project and subsequently served as an international coordinator and lead researcher for the Horizon 2020 funded Surge Africa project, which strengthened district-level surgical systems in Malawi, Zambia, and Tanzania. Dr. Gajewski currently leads and collaborates on several implementation research programs in Malawi. He is co-principal investigator of the Akazi Breast Cancer Program, RCSI co-lead of the Surge Water Project, addressing water security for maternal and surgical care, and leads the Kids Surge, a program strengthening pediatric surgical capacity at district hospitals. He has published extensively on health systems, workforce development, implementation research, and global surgery in low-resource setting. I am excited to hear what he has to say and what he has for us. Please do welcome Dr. Gajewski. Dr. Gajewski, we're happy to have you. Please go ahead.
Thank you very much. Can you hear me? Can you see my slides?
We can see you, not your slides, and we can hear you perfectly.
Okay, that is strange because I am trying to share my slides. One sec, let's give it a go again. Something isn't right. One sec. My slides. Share. It seems like I'm sharing, but I'm not sharing. More. Where is the share option? The share option has disappeared, unfortunately. Maybe I'll join again, okay? Just give me 5 seconds. I'll try to do it again because it's not working for some reason.
I think
as
it's
he
been,
is trying.
yeah.
Oh, go ahead. Go ahead, Bishop.
Thank you. Thank you, Nyangwe. I think it's been such an interesting morning of so many diverse talks on innovation in women's health. As Dr. Gajewski is trying to get his slides up and join us again, I think it's a nice opportunity to stretch our legs and grab some tea after such an intense morning. So we'll give him 5 minutes to rejoin and share his slides, and hopefully we'll be back soon. Thank you.
Thank you so much. And just a reminder to everyone, please do ask your questions, put them in the chat, and we'll read them out for our presenters. Thank you so much. Okay. If that's Dr. Gajewski, we can see your slides now, just the full screen.
Hello? Can you hear me now?
Yes, we can hear you and see your whole screen. So not just like slide presentation. Yeah.
Can you still see the slides?
Not at the moment.
Oops. So I don't know what's happening because when I'm trying to make them full screen, they disappear. That's the problem. Share. Let's do it now. What if I share now? Share. I'm sharing it.
You can see your full screen. Yeah.
Okay. And then what happens if I do this? It disappears?
Yes, it does, unfortunately.
Share. Let's see if I share this now. Is it better?
Yes.
Let's give it a minute. Is that
Can you
okay?
see the slides now? I think you should.
Yes, we can see your whole slides, yeah.
All right. I'm very sorry about that. But I think I'm ready.
Yes, please go ahead.
Okay, so we'll be talking about something different now because I think we've talked about AI, and I'm gonna bring you to very rural places in Malawi to talk about something that doesn't really need AI, something that really is the most simple technology you can think of, but it's gonna hopefully make a big difference to a lot of people. The title of the talk. Thank you very much for the introduction. I have to say, I was kind of also curious to hear about myself. I haven't really read the bio in a long while. Yes, my job is primarily to do with implementation research. Most of my work is in sub-Saharan Africa, and we try to develop elements of the healthcare system delivery, test them, evaluate them, and scale them up in low resource settings. And the story that I want to talk about today is the story of the Surge Water Project, which is about strengthening rural health services in Malawi, asking a question, can rainwater enhance maternal health? And I'll tell you shortly why. First of all, it's an international collaboration between Ireland and Malawi. We have, and it's not only international, but I think at the scale of the project that we are, it's truly multidisciplinary, the work that we do, because you have from UBAS, which is Malawi University of Business and Applied Sciences, Professor Kambala, who is a maternal health specialist, myself, we have Professor McGuigan, who is a physicist, we have a set of health economists, we have engineers, we have communication specialists, we have lab technicians, medical doctors, and a range of other people working together for one aim. And the problem that we are trying to address is really very well displayed on this picture. Let me talk you through what you can see. This is a maternal antenatal ward in one of the district hospitals in Malawi. It has a bed capacity of 40. However, at the moment when this picture was taken, there were around 70 women. They were all pregnant. They were all expecting. And the only source of water that they had in that ward was the blue bucket that you can see in the middle. So for all the sanitary needs, cooking needs, and all the different things that you can think about that water is related to, the source of water for these 70 women was that bucket. That's of course not an ideal scenario. And we thought that this is something that we can work on and we can hopefully improve. So before I talked about the solution, I want to kind of paint a bigger picture about what the problem is with water. And I think I can start with a statistic that over 70 million women per year give birth in facilities without adequate water, putting lives of themselves and their babies at risk. And that is really a huge statistic when you think about it, that 17 million women give birth in facilities, in our case, in facilities with no running water or no access to piped water. What makes it worse is the global warming, of course, drought or floods in countries like Malawi. I think there is a recent news that El Nino is likely to hit northern Mozambique and southern Malawi again, which is going to be devastating yet again. So whatever water sources are there, they become contaminated because of the floods, or they dry out because of the global warming. And of course, without water, healthcare workers cannot carry out any infection prevention controls or sterilization, and that has negative consequences on the quality of care. So that's really where we're at. We did also, I don't have a slide for it, but we did a national survey of all the facilities in Malawi, healthcare facilities in Malawi, and over 60% did not have running water in the maternal room. So, and you can see this is another picture of a maternal ward in a smaller place, in a health center in a rural village, And again, the same thing, there is no tap, there is no sink, there's no water, and all the water that these women have is the water that they bring themselves from a borehole. So what we came up with is basically technology that uses two things that Malawi has in large quantities, which is rainwater, because there is a 4 months long rain season and it rains quite a lot. Also, throughout the year, there are sporadic showers and rains. So there is good availability of rain. And of course, being in sub-Saharan Africa, there's plenty of sun. So how does the technology work? You can see in the picture, we collect the water from the roof of the clinic. It's piped through the white pipes through these 10,000 liter tanks. So the capacity to store water is around 20,000. Then you have these plastic tubes, which is something that we call the SODIS reactor, solar disinfection reactor. The water stays there for about 6 hours. And then once it's drained into the blue tank below, the water is basically safe to use, because what the UV light does, it kills all the pathogens that are in the water. It doesn't treat chemical pollution, but you wouldn't expect chemical pollution in a water that comes from a roofs facility. We do water quality testing, so I'll show you the results, but the water is basically safe. So we can produce around 500 liters per day, because we can do 2 batches in a day. So that's really the capacity of the system. The advantages, we are harvesting rainwater. Like I said, the rain falls for free. There's no cost attached to it. The sun UV light is freely available as well. So it's completely nature-based solution. There are no consumables or running costs. So once you put the reactor in place, it just stays there and it does the job. The life expectancy of the plastic tubes is around 10 years. So I think it's a good period of time. We've done a cost effectiveness analysis. The paper is just published, I think, yesterday or the day before yesterday, and it shows that for every dollar spent on our system, there is a gain of around $1,000. The reactor does not rely on electricity, and that is very important, because in rural settings in sub-Saharan Africa or other regions of the world, but which are not very well developed, there are frequent blackouts, which means that there's no electricity. So if you have something that depends on the electricity, it's not going to work. And really, the big benefit is that if you can look at the sink there on the picture, the water is really there in the maternity room. So people can wash their hands, they can wash their instruments, they can wash the room. People can wash themselves. The mother can wash herself. The baby can be washed. So there's a lot of advantages compared to the previous situation when the reactor was not there. How did we do the work that we did? Basically, to get us to the point of defining what the solution should look like and would look like, and how to deploy it and where to deploy it. We've done an extensive research assessment. We used the so-called PESTEL analysis, which basically looks at political, economic, social, technical, legal, environment aspects that might affect the deployment or the implementation of our technology. I don't want to go into the details, but I think it is what is important to say, because it's becoming more and more popular in the implementation research, that we have a lot of ideas, but if you look at what happens on the ground in a lot of low-income countries, very few of those ideas actually translate into something that people use on a daily basis and benefit from. So I think these kind of the social science angle, which is, for instance, this kind of analysis, brings any idea that, as we call them, sounds like a good idea at the time, to something that people can use, because you explore the barriers and enablers early on as you develop your solution. Just to give you an example of how important this is, the title surge water comes from the fact that initially we wanted the reactor to be placed at the district level in a hospital, because we know that there are frequent water shortages, blackouts, so the water is not coming and you cannot sterilize your instrument. Surgery cannot go ahead, so people are referred unnecessarily because of these shortages. But when we did our PESTEL analysis, we identified some legal challenges. And one of those legal challenges is that there is a single company, which is the Malawi Water Board, that provides water to all the government facilities, and the service is prepaid. So a hospital needs to buy water for the month. And once that water is used, that's it. So the way it works is the hospital has a budget for water. They spend the budget, prepay for the water, and people are free to use that water. But what happens oftentimes is that halfway through the month, or let's say the third week or fourth week of the month, that water runs out, leaving the hospital with no water. So we came with a solution, and we said, okay, we'll come up with a backup plan. So whenever you don't have the piped water, we'll give you the water for free. But the Malawi Water Board says, look, if you do it, we'll sue you, because we are the monopolists. We don't want any competition. We want people to pay for water, and you're coming with a free solution. So that is not going to work to our advantage. So of course, as a research team, you don't want to end up in court. And we decided to change our direction. So we went below the radar of the Malawi Water Board, and we started to work with health centers, which are still within the government public health sector, but the Malawi Water Board does not operate at that level. So we decided to change our approach from applying our technology in 3 district hospitals, and we moved them below that level to health centers. The health centers are quite big. They have quite a lot of clients, quite a lot of patients. Some of them act as district hospitals or rural hospitals, although none of them has a theater at the moment. Also, I want to say a little bit about the intervention, because also what we see from the social science part of research is that oftentimes people come up with a fancy toy and say, okay, just use it. It's going to make your life different. They bring it to the people and say, oh, look, this is a great tool. We've validated it in the global north. It's safe to use. It's whatever. But you go there a month later and you see people are not using it. And why is that? Because I use the example of a phone. Certain phones we like, certain phones we don't, and whichever one is the one that we like, we use. So that same thing applies to any other technology. That it has to be user-friendly, it has to be practical, it has to be enjoyable, it has to be meaningful. There is a lot of things that people attach to the use of a particular tool, which are often things that are not often considered when these things are deployed in low resource income countries or places that would technically benefit from that technology, but might not be, for instance, ready to receive such a highly advanced or highly technical gadget. So we've put a lot of work into making sure that we find the right fit. So first of all, the places that we decided to work with initially were 2 places, Tekarani Rural Hospital and Chimvu Health Center. We picked places which had absolutely no water on site. The water was coming from a borehole that was around 15 meters walk from the health facility. So every delivery, the pregnant woman needed to fetch water in 2 buckets, deliver the baby, fetch more water to wash herself, wash the baby. So very uncomfortable situation. But we thought, okay, this is a good moment. This is a good place because people clearly have the need to use this technology. The other aspect of that intervention was to train the health facility in how to use it, because of course the project team cannot be there all the time. So we needed to train. We trained everyone who was involved in the facility. So everyone knew how to operate. It's basically open one valve and close another valve, or close one valve and open another valve in a given time interval. But we also involved the local community, the local villages, the local chiefs in the construction of the reactor. So for instance, the plinth that you can see on the picture was built by the local people, because that creates a sense of ownership. That creates something of a sense of, okay, this is for us and we contributed to developing it, which is important in terms of long-term maintenance and sustainability. We've also done orientation sessions, because there were in our initial assessment prior to deployment of this technology, we identified that people have certain beliefs around rainwater, and it was important for us to demystify that. So for instance, people are thinking, oh, the rainwater is not safe, it feels different on the skin. It's, I don't remember exactly what the issues were, but people were not really fond of using rainwater for anything. So we did a few demonstration sessions and orientation sessions, just for people to understand that the water actually that comes out of the blue tank below the reactor is safe. So, they got to understand that. The big aim was really to reassure the people that the reactor is there for their benefit and that it's safe to use. This is a busy slide, but I think I want to also pay attention to the COMB model, which is part of behavioral science, something that is often useful but not often used. So it's just basically an exploration of what the capability of the local team is, what are the opportunities to use it, and what is the motivation. What is the motivation of people, that might be benefiting from the system? So just don't need to pay attention. If you want to follow up, you can really Google the COMB model. It's very useful when it comes to implementing any technologies or anything on the ground. After we've deployed our system, we did an evaluation, and we focused on a few things: antimicrobial, of course, water quality analysis. So we sampled the water every week or twice a week initially. We also wanted to see how much water can we produce within the clinical environment, how much water is used. And we've also did a mixed methods study to analyze the feasibility, adoption, and effectiveness of our intervention, basically to understand, are people comfortable using it? Is it feasible to have this technology on the ground? And what's the effectiveness of it? The research questions were really around that. Is introducing SODIS technology a rural health facility feasible? The answer is yes, it's feasible. What is the effect? The effect is you have around 500 liters of good quality water available on the site. What is the experience of technology users? And there is a bit of work to be done. I'm going to talk about it in a minute. The user experience was not perfect, to say the least. People struggled at times and there were challenges. And of course, we also wanted to look at the effect of the intervention on maternal and neonatal care services. This is, again, another busy slide, which is about the water quality analysis data. You have the first 5 weeks of when the water was not treated. Week 6 on the picture is when you have these 2 little stars. It means that the reactor was introduced, and then you can see that there is a drop in E. coli and the totocoliform for the subsequent weeks. The data in red shows that the water was not treated according to our standards, but then when we explored what happened is really that people did not follow the protocol, so there was still a little bit work to be done in terms of training and retraining and making sure that people really adhere to what the operating manual says. So preliminary data, is no longer preliminary. We've been doing it for 2 years, so maybe I should have changed on the slide. It's not preliminary. We've consistently provided 250 liters per day, in some instances 500 liters. When the water is treated properly, which is it stays at least 6 or up to 6 hours. Actually, it doesn't need to stay more than 6 hours. It meets the national E. coli standards for drinking water and total European Union coliform standards for bathing water. What was our big question is, are the 20,000 liters tank going to be sufficient for the entire year? Between the rain seasons, there is only sporadic rain. But the answer is yes. It's enough, which was great for us because the water was available throughout every single month of the year. But on the other hand, we've also learned that putting the harvested rainwater, so this reactor, on the ground of a facility creates more demand for water because people see, okay, there's water, let's use it for one thing, let's use it for cooking, let's use it for showers, let's use it for washing clothes, and the demand is really self-generated there, and it's increasing. So with there's work to be done in terms of making sure that the water is used for the most essential bits, which is what the intended idea was, or the intended the plan was. And not being wasted for things that might be done with the borehole water or untreated water, basically, because rainwater, you can use it for washing your clothes. So what do we know about the different benefits? Improved service delivery. There is less time needed between the different deliveries because the water is available on site. So there is no need to go to the borehole, bring the water, and then deliver the baby. So that's a big thing. And that, if you compare it between the previous situation, the current situation, we are talking about the gain in between 30 to 60 minutes. Another thing that we've observed is also improved compliance with IP control, infection prevention standards. People hand wash more often. They wash the room, they sterilize the instruments, and it's all looking better than previously. The water is for free, so lower water-related costs for health facilities. There's no need for pay. There's no need to send anyone and give someone a little token money to say, can you fetch me water? Because there's no need for that anymore. There is also reduced risk associated with fetching water at night because there were reported instances of sexual assault when women were queuing at the pump, waiting to collect the water at night. That risk is now removed because the water is there. And of course, improved patient-staff relationships because there is, the quality of service has improved. And lastly, but it's also very important that because some staff lives, some of the health workers live on the ground of the facility, there is staff housing, which were also affected by the fact that there was no running water. Right now, their living conditions are better, so they're more likely to stay there and work in these conditions because they have water. Simple as that. So what we are doing now with the technology, we have built the reactor. The initial reactor was built in Spain and shipped to Malawi for field testing. What's happened last month, we've built the first reactor on the ground in Malawi using a Malawian company, which is great because we want the product to be sustainable and locally available and built out of materials that are available in Malawi. The only things that are not available in Malawi are is the plastic that the material of the reactor is being used, but Malawi imports most of the things that the country sells. They manufacture very little. There's very little industry in Malawi, so there is still huge reliance on import. So that's not a big deal. The good thing for us is that you can get this, we call them PMMA, plastic, kind of plastic, acrylic glass type of plastic from South Africa and from the nearby countries and ship them in Malawi. We've changed the design. Like I said, there were you might remember from the previous pictures that the original design was based on tubes. What turned out to be the case is that cleaning, sometimes you need to maintain them because there is a little debris, or sometimes the inside of the tube is getting some whatever bacteria grows and there is some film for, so you need to wash it. So people struggle with opening the tubes and reaching through tube that is that long to clean it. We changed the design of the reactor. I'm going to show you what is the new solution now. We also, because, like I said, we've learned that the rainwater is not really trusted. We launched a campaign which is called the Catch the Rain campaign. I'll tell you a little bit about that. Because we want to change the social perception of rainwater among the Malawian society. Because if you think about countries like Uganda, Rwanda, but even South Africa, so-called JoJo tanks, people collect rainwater and it's just a normal thing that everyone does. In Malawi, that's not necessarily the case because the perception is influenced by the way people think about rainwater and what you can do with it. Yet it is there and it could be used. So this is one of the things that we're working on. And impact pathways, we are a research team, we are a non-profit group of people. We want to develop an open source technology that others can take, maybe commercialize. And that's why we engage with the business community to say, okay, look, this can work. You can manufacture it in Malawi. Maybe you can try to turn it into a business. So that's really where we are at. The new change of the new design of the reactor is really looking like this. It's no longer a tube. It looks more of like a coffin. And you can open the coffin and clean it from the top. So you have on the right-hand side the tank cover and the actual tank on the left-hand side. So it's much simpler. It's much easier to use. You can two people can lift the cover, wash the tank inside, put the cover back, and the reactor is back up and running. We've also changed, you remember there were the green tanks, the 20,000 liter tanks. We've also used so-called calabash tanks, which are tanks that are made out of concrete and locally available materials. They were way cheaper. They're easy to repair because they're made of concrete. If there is any crack or anything, you can just put another patch of concrete and the calabash tank is going to be there. That's the new reactor that was just deployed 2 weeks ago. We are testing its performance in the first place, hopefully getting good results. We've tested it in Spain. We had some issues, but we fixed the issues. Hopefully now the reactor is going to be working very well. And that is another thing that I want to highlight. The guy in the middle, I don't know, maybe some of you know the kind of music which is called amapiano. It's very big in sub-Saharan Africa, particularly in South Africa. And the guy in the middle is called Zeze Kingston. He's the #1 amapiano artist in Malawi, has millions of followers. He's very big. He was actually touring the UK and Ireland, so we wanted to him, but I was actually on out of country. But we partnered with him and he created a song for us, amapiano song, which is called Mazi. You can check it out on his Facebook. It has already a lot of comments, a lot of thousands of likes, and I think 11,000 likes. So you can imagine that, the scale. And the song is really bringing the message, water falls from the sky for free, take care of it, we can use it. And that's really what the kind of simple message that we want to say, because as a research people, we thought how do we make a change? Our usual communication channels are research papers or conferences, but this is not something that the ordinary person listens to, and our message is never going to reach. So we thought let's be creative, let's do something different. So we've partnered with Zeze and we're going to have a dance challenge. So if you want to entertain yourself and do our dance challenge, it's going to be launched, I think, this or next week. No, this week is end. This is finished next week. Yeah, and it's going to be, hopefully when I go to Malawi and I hear that song in a club or on a radio, it's going to be a big success for us, because the message reaches the youth, the people who can make a change, to make a cultural shift in terms of rainwater perception. And that's really it. I think these are the slides just to show the work that we've done so far. And I'm happy to take any questions. Thank you very much for having me.
Thank you so much, Dr. Gajewski. That presentation was amazing. I think it's very interesting. I'm excited more so about your last bit about Manzi with the amapiano presenter, because in my country, Manzi is similar to what he's saying, Manzi, which is water. So this was an exciting presentation. Thank you so much. You're doing quite a bit, and the creativity is also interesting. So we have a few questions for you. The first, sorry?
Go ahead. Happy to take any questions you might have.
Great. So Dr. Vijna asks, she states, first of all, that she finds it heartbreaking to think that women in their peripartum period have to bring their own water for delivery and needs, and it's what you're doing is such an important initiative. She likes how you engage the community with the key actors and all of that. So her question is, do you think that access to WASH, the water sanitation and hygiene, is still often treated as separate from surgical system strengthening?
Yes, and I think that's one of the questions. That's a very important question, because that's one of the questions that I got from the people that they work in the global surgery space. I was like, "How is that global surgery?" I'm like, "It's the essence of global surgery, because you cannot do anything to do with surgery if you have no water." I've been working in surgical system strengthening for nearly 15 years, and one of the major problems that you find on the ground in those facilities and you say, look, we cannot use the sterilizer because we have no water. So unnecessary referrals, which hugely drive the cost of surgery up for the healthcare system for the entire country. People don't think about it, because I think the weakness of global surgery in a way is that it thinks of theater only or surgical training only, and it omits the things like simple things like, is the road good enough for the ambulance to get to where the patients are? That causes massive delays when it comes to access to surgical care. When the people go to the facility, was the quality of the service beyond surgery? You remember the picture of the ward? If you have 70 people, which is nearly twice the number of people that should have been on the ward, and all of them rely on a single bucket, that also feeds into the overall experience of a surgical patient. The experience is one thing to mention. The other thing is infection rates, wound cleanness. If you don't have water, how can you might do the best job as a surgeon, but if the patient goes back to the ward and there is no water, and they cannot wash themselves, they cannot maintain the basics of the hygiene needs, it's just not going to work. So I think we have to go beyond the purely surgical system to think about the quality of care and the access of care that we often talk about in surgery to really make a difference.
Thank you so much, Dr. Jakub. Dr. Vijay, our first speaker, also has a question. He asks, what is the cost of one kit? How much water can one kit produce in 24 hours? And can it be used to treat lake water? So it's a 3-in-1 question.
Okay, so the cost of a single reactor I think is around $3,000 at the moment. We're trying to bring it down, but that's realistically where we're at. It can produce, like I said, 500 liters per day. So that's the 500 liters is maybe a little bit arbitrary here, because what happened is, like, we looked at the water quality, the water quantity needs of these facilities before we designed our reactor and circuit, and we estimated that the bare minimum is around 200 liters. So we topped it up by 550 liters, and we said, okay, we can give them 200 liters guaranteed per day. But if the weather is good, they can do 2 batches, which is 500 liter. But the reactor can be customized. We haven't really done it because we are kind of still focusing on the first design. But I think that in future we can produce bigger quantities. Can it treat lake water? Of course it can. It's just a matter of connecting it in a way that the water from the lake gets into the reactor. And yes, it can. UV, B, and C light is going to kill all the pathogens. It does the same to the pathogens in the water that it does to human cells on the skin, which is burn them and disintegrate them. So it's the same mechanism. So it doesn't really matter where the source of the water is, and as long as it's not chemically contaminated, because the chemical contamination requires a different type of treatment. So that's the only caveat here.
Okay. Thank you so much. John Dalton says, wonderful presentation. And he asks, can I ask if you think that that had applicability in urban settings too? And also whether you've considered any innovative ideas for sterilization of instruments such as birth kits and others?
Yes, we believe that there's a big potential in urban settings. I think our focus, because we are health systems researchers, we wanted to bring this technology to the clinics, and this is the first big innovation, because this technology, treating water with sunlight is not something that we came up with in this project. It's been around for around 25 years, but this project is the first one actually ever that brings its benefits, or tries to bring the benefits to the into the healthcare sector, because we know there was such a gap in maternal health, in like some of you said, it's heartbreaking to see that women have to, you're about to deliver, you have to go fetch the water. After you've delivered, you have to walk back, get the water. You know, I have a nice, it's not a nice video, but it's really it's kind of a very sad video about a woman who was 17, and she said, look, when I delivered my baby, my mother was not there, and I needed to go right after I delivered the baby, leave the baby with the local staff, go fetch the water because I needed to cook. You know, so that's yeah, that's what we are dealing with. But you can bring the same reactor to a school, you can bring the same reactor to a community that doesn't have currently a good source of water. You can deploy it there and people can benefit from it. So of course, yes. And in terms of innovative sterilization techniques, that is a little bit beyond the scope of this project. So the answer is not really. We have not thought about it yet, because our focus is just to get water to where it needs to be. And then whoever is there, they need to think about how they can use it. The intended idea of the Surge Water project was that we can bring reliable and good quality water to the autoclave machines, so it's always there and people can autoclave water on instruments on a continuous basis. But like I said, for political reasons and you know, no one wants to end up in jail or fined, we needed to change tack in the project.
Right. Thank you, Dr. Jakob. I hope that answers your question, John. Another question, I think we'll squeeze in this last question from Surya Awal. She states that rural areas and PHCs in general are almost always lacking in basic medical facilities and supplies. It would be interesting to learn how much a role the Ministry of Health and government in general played in this breakthrough, sir. So that's a question to you, Dr. Jakob.
Okay, perfect. That's a great question. I think that also speaks to our heavily social science oriented approach, because we pick the partners that strategically for our project. So the local PI in Malawi, she is a very well-established professor in public health. And who do you think are the people at the Ministry of Health? They are the graduates. They are her graduates. So whenever we go to the ministry, say, "Oh, hi, prof, what's up? You know, it's been a long time." And so they remember her. She might not necessarily remember all the students, but they respect that person quite a lot. So I think it's a strategic move to find your stakeholders from the get-go in any project and initiative that you do, because that brings the ministry on board immediately, because they're not going to say no to their professor. They're going to be more lenient, more collaborative, more willing to support the cause of their teacher, especially if they respect the teacher. So there is a big role. All the different stakeholder engagement meetings and all, you know, there will be an event. If you happen to be in Malawi on the 5th of September, we are organizing a big concert. It's going to be an open concert for public. We are expecting thousands of people to attend, and Zeze is going to be the main star, but we are bringing also the ministry people from the local authorities and other places to emphasize that there is a need for a discussion in the public domain about the benefits of harvesting rainwater, not to mention treating it. Treating it comes next, but in a country that does not culturally accept harvesting rainwater as a way of preventing shortages of water, I think there is a need for a debate. So we are doing a lot of things, and we are benefiting from the links that we have directly or indirectly with the different ministries. It's not just Ministry of Health, but yeah, that's really, they play a big role, long story short, yes.
Right. Thank you so much, Dr. Jakob. I mean, just quoting from what Dr. Fran said when she went to her dark side a bit, which I agreed with, is someone has to pay. So thank you so much for your presentation. It was lovely. We've learned so much, and how water, something as simple as water, does affect equity to good health. My part at this point is done. I will invite our president, Dr. Vishna, to come through and take over. Thank you.
Thank you very much. Thank you very much to all our speakers. Thank you, Dr. Ismavel. Thank you, Dr. Kurht. Thank you, Dr. Fran, and thank you, Dr. Gajewski, for such a fantastic morning. We've spent 2 hours this morning reflecting on and learning about some of the key innovations that are happening in women's health around the world. And I'm just astounded by the breadth of work that's happening. So we considered technological innovations intra-operative innovations, but we also looked at health system innovations, social innovation. We looked at health system innovation as well. And very interestingly, we looked at new ways of spreading the word and engaging people. So really looking forward to the concerts, and I'm going to play that song that you shared, Dr. Gajewski, after this. To end a fantastic morning, I would like to announce the results of our essay competition. So we ran an essay competition earlier this year on innovation in women's health. And what we asked you to write about was, we asked, innovation or inequality, who benefits from new O&G technologies? We received a large number of entries, and thank you very much for sending your entries in. It was such a delight to read all your entries. It was a very, very tough competition, and we had the hard job of having to select the winner and the top entries. I am delighted to announce that the person who has won the GASOC Innovation in Women's Health competition is Ariella White, from the UK, who wrote on the innovative technologies surrounding womb transplant. Congratulations, Ariella White. We'll get in touch with your prizes and your certificate. I will also mention the runner-ups, but just because the entries were of such high quality. So the second place goes to Shamim Faraz, who is a medical student from Nepal. And we have got a tie for the third place. That's how high the quality of these entries were. So we've got a tie for the third place, which go to Dr. Igbo Amarachi Mary Prudence and Brigitte Benny. So congratulations to all of you. We will get in touch with your certificates and any prizes. Thank you so much for participating in the GASOC Innovation in Women's Health competition and the event today. It has been such a fantastic morning, and it has been a pleasure for GASOC to host such incredible speakers. Thank you so much for giving your time to GASOC and sharing your insight and expertise with us. And thank you to all of you in our audience who have stayed with us throughout this morning to learn from all these amazing speakers. Thank you for your time, and thank you for your partnership in this journey. Keep an eye out on the GASOC socials and our newsletters for any upcoming events. If you would like to get involved, we've got places on the committee, vacancies going live soon over the summer, so keep an eye out, and hopefully see you soon at our next events. Thank you so much again to all our speakers and all our audience. I will try to play the song that Dr. Gajewski sent and share my screen, but I'm not sure if that will work, just as an ending to this conference. Let's see if that. Yeah, I don't think that's working, but thank you so much, everyone. We'll put he's put the link in the chat, and we'll take it from there. So thank you very much. I'm going to end the meeting now. Thank you. Bye.